Treatment of ovarian cancer remains challenging despite high responses after maximal surgical debulking and platinum combination chemotherapy, as most patients unfortunately will experience relapse. In what situations, Tate, would you recommend neoadjuvant chemotherapy instead of primary surgery?
Well, if we look at the two major trials to date that have been reported in detail, looking at neoadjuvant chemotherapy versus primary debulking followed by chemotherapy, those studies showed no difference in overall survival. So those studies would suggest that you could select any patient you wanted to for neoadjuvant chemotherapy. Now, that's not what we do in practice. We still have a basic belief that upfront debulking is the proper way to proceed with ovarian cancer. And on that basis, our day-to-day practice is to recommend neoadjuvant chemotherapy only in those patients who, for a very good reason, are not candidates for upfront debulking surgery. That sort of is in a nutshell the way we approach that now. And I think that probably reflects U.S. practice.
I think so. I think that's the initial consideration. Obviously, patients with presumed advanced disease need to pass the bar in terms of safety. And so if there are major comorbidities, severe malnutrition, that would help us predict that a patient would do well and have an acceptable morbidity rate, and the disease could be deemed potentially completely resectable surgically. I think that would be the minimum bar that would have to be passed, but I think in general that's true.
Yeah, I mean, obviously we look at the performance status as has been discussed. I think the trickiest part of this field is having reliable preoperative markers determine who can be debulked or cytoreduced successfully, and we don't have that. And so in many ways, when we have a patient who has a large predominant pelvic mass and ascites and mental cake, we still don't know whether or not that patient's going to undergo what we define as a successful debulking procedure. And so, we'd love to have that marker, but still, we largely base it on their medical comorbidities and their performance status. And if they meet a certain threshold, those patients may be better served with neoadjuvant chemotherapy than a primary debulking.
Yeah, there are a couple other things too that probably should be mentioned. I referred to two European trials that suggest that neoadjuvant chemotherapy and primary upfront debulking are equivalent. You need to understand too that there is some question about the quality of the surgery in those trials. The debulking rates for primary debulking surgery across the 9 countries that participated in one of those trials range from 83% in one to as low as in the 30%, in one of the other countries, so that there's quite a variability in the frequency with which one achieves so-called optimal debulking. And the second odd thing about those two trials is that even though the ability to debulk to no gross residual was greater in the neoadjuvant chemotherapy group, that did not lead to a survival advantage, and one would think that it should have. So there are some issues in those two trials that I think raise serious questions about the approach of neoadjuvant chemotherapy at the current time. So that's one reason why I'm a little uncomfortable saying you can simply choose which approach you want to take, end of story.
So one of the conclusions of that is, as a medical oncologist, is to turn to my gynecologic oncology colleagues and say, will you be able to get this patient down to zero volume disease, which versus not? Because if the answer is, I don't think so, then it makes sense to try the alternative approach. So that leads to the question.